going to be a great opportunity to share two sides of the pediatric epilepsy equation. A warrior mama navigating the journey for her baby, and a pediatric epileptologist providing the highest level of care for children suffering with epilepsy. Dr. Sucheta Joshi is a pediatric neurologist and epileptologist and the medical director of the Pediatric Epilepsy Program at the University of Michigan. Dr. Joshi cares for infants, children, and adolescents with treatment-resistant epilepsy. Her clinical interests include improving access to care for children with epilepsy and increasing the use of telemedicine. Welcome, Dr. Joshi. Thanks for joining us.
Thank you so much. Thank you.
And Dami Quiñones is a warrior mama to our little Mickey's Miracle warrior, Marley, and has been in this journey for a little while now. We've become very close, and we are so honored to have you here to share your side of the story navigating pediatric epilepsy. Welcome.
Thank you for having me.
And I'd like to also introduce
yeah, I'm sorry, Christy, go ahead.
I wanted to introduce you, Dario. We're just so excited.
I'm so excited to see these amazing faces.
Welcome, Dario Herrera, my co-host for the Pediatric Epilepsy Podcast.
I get so moved, honestly, Christy, when we have people like Dami join us, and she's on the front line, and this is people like her are why we do what we do. And it makes me so inspired and so hopeful and in many ways sad too, because I know the struggle that she's, I mean, you know it better than me because you're in contact with her every day, but to see her like show up and be brave and always have a smile on her face really moves me like every time, you know. And then, you know, Dr. Joshi is so gracious, you know, she's in spring break now, so she has a little bit more time than normal, but you know, her plate is very full. You know, and it's such an honor to have her join us, you know, and she has dedicated her life to people like Dami and her child, right? And it's so moving to me to be able to facilitate a conversation, you know, that Mickey's Miracles gets to be the vehicle that brings these conversations together, and your visionary leadership in creating Mickey's Miracles. I know this was part of your vision, you know, when you did that. So it just, for me, I feel like, you know, like an observer that gets to be in the sandbox.
No, not by any means.
Not really, I mean that because the level of work that each of you have done, not just today, but historically to get to this point, you know, in your respective journeys is moving to me. It's inspiring to me. And I'm grateful to be here, honestly, you know.
Thank you, Dario. I completely agree. I think what you said, that keeps showing up. And this is the reason why we started Mickey's Miracles, was that when we were in the fight for Mickey's life, I didn't have anybody to turn to. I call organizations and never hear a call back. And the sense of urgency and how important it is to have an urgent reaction from the medical community. But in addition, just to have the support, knowing that Dami can call us, or now we've connected to other, you know, parents in the fight, and you just don't feel so alone, and it's completely rewarding. So we're so excited to be here and to have you guys be a part of the Pediatric Epilepsy Podcast. I think I'd like to just start it off by, you know, Dr. Joshi, could you just share a little bit about, we talk all the time about what a pediatric epileptologist is, what a level 4 epilepsy center is. Can you share with our audience what it is that you do and what your center does and why it specializes in epilepsy?
By all means. So a pediatric neurologist, just to start sort of from the basics, is a doctor who has trained in pediatrics and then has had a dedicated time in pediatric neurology. We like to call it child neurology. And then a pediatric epileptologist spends anywhere from an extra 1 or 2, sometimes even a little bit more years training to read EEGs, which is a common thread for diagnosing epilepsy, and also managing children with complex epilepsy. This includes surgical management, this includes dietary therapies, this includes knowing about new drugs. So really a very comprehensive management of pediatric epilepsy. There are several hospitals that sort of cater to the needs of children with epilepsy, but comprehensive epilepsy centers are places that are certified by the National Association for Epilepsy Centers, what we call NAEC. And there are different tiers of certification. So level 4 is the highest level of certification that an epilepsy center can get. And this usually means that this is a place that provides comprehensive care. This is a place that has trained epileptologists, has the right kind of trained technologists, the right kind of EEG equipment, the right kind of EEG services. Again, all the new greatest treatments are offered for epilepsy, which are not just limited to new drugs, but also dietary therapies. There are surgical treatments that are offered, and these can range from identifying the source of epilepsy and being able to surgically remove it to something much more complex and sophisticated, like mapping out where a seizure focus is. Is it safe to take it out? What kind of functional brain tissue are we dealing with? So those are all the specialized services that are provided. And now with even more advances made in epilepsy treatment, deep brain stimulation is at the frontier of new epilepsy treatment. So level 4 epilepsy centers provide that also. So that was my epilepsy center, level 4 epilepsy center 101 in 30 seconds.
Great job. And
What a great answer.
What was it? It is. She nailed it. Dami, what was it? Why was it important for you to get to a level 4 epilepsy center? Why did you make that decision for your daughter?
So we had got to the point where our home team, I felt at the time basically just gave up on Marley. She was declining. She was getting worse. Her quality of life wasn't so great. And I don't know. I couldn't accept just that. Just accepting like, oh, she's getting worse and there's nothing we can do. So I guess getting to a level 4 epilepsy center, it helped confirm what was really going on. So, and if there was anything else that we could do, then I knew that I was giving Marley the best care possible that I could give her, and that we tried everything that we could try, and we gave her what she deserved. So getting to a level.
And where are you now with her treatment? Tell us a little bit, since you've gotten to that higher level of care. What is the next plan in her treatment?
So when we got to the level 4 epilepsy center, we realized that one of the meds that Marley was on was actually triggering more seizures.
Wow.
Marley was having like constant like tremors. I don't think she ever like was still, even when she was sleeping. Like her body was always moving, and so that was a big thing. When we got her off that med and we replaced it with another med, her mood changed, her seizure activity. Now, from the outside looking in, Marley doesn't look like she's having seizures. She just looks like a perfect little baby. But when you look at her EEG, it's like nonstop. And so that was a hard thing for me to like understand, because I'm like, what do you mean? She's just twitching a little bit. So now we're to the point where the meds aren't stopping her from seizing, but they're keeping her at a good place. Exactly 2 weeks from today, Marley is having her surgery. Finally,
Wow.
she is having a hemispherotomy with a temporal lobe removal.
Okay.
Which is a hard pill to
Deep
swallow.
It is.
Yeah.
I don't know. Like I never thought I'd be so excited about my daughter having one of the hardest brain surgeries in the world. Like I never thought I'd be excited, looking forward to this day. But I feel like it's gonna be the best day, because it's gonna give her a chance at a better life. And if we hadn't met you guys, and if we hadn't gone to the level 4 epilepsy, I don't know if we'd be here today.
And tell it and explain for somebody, you and I, before, we had our little girl seized, we didn't know what this was about. We didn't know how devastating it was. We didn't know.
No.
Can you explain why is it? What is the alternative that you're currently facing, and why would you be excited for brain surgery on your daughter?
Like, the seizures have completely took over her life. It takes away her ability to roll over. It takes away her ability to enjoy eating. She's eating, and then 5 seconds later, enjoying it, 5 seconds later, it's a total disaster. It stops us from being able to have fun as a family. It stops her from resting. She can't even rest at night. And with Marley, everything happened so quickly. So she had a seizure at day 5 of life, but she did have a severe brain bleed. So we thought once we'd control the hydrocephalus, the seizures would go away. Last year, April, we had a hospital admission for some abdominal surgery. She ended up catching a shunt infection. So, of course, they did an EEG. When they looked at the EEG, it was nothing like they would have expected. She was just on Keppra at the time at like a little maintenance dose. And we had no clue like what was really going on. And I had seen some like abnormal movements, but I thought, she was a preemie. She was tiny. Like, I didn't know what was normal, what was not normal.
Especially for a first-time mom.
Exactly. And then like
babies do weird things. Little infants do
when did
movements.
When did you first think like this isn't normal? I mean, I've heard Chrissy recount, her experience with Mickey, and that she just knew as a mom that instinct, her mama bear instinct told her like, this is not normal. I don't care what the doctors say. This is not normal. When was that moment for you?
I think,
how old was Marley?
First of all, her eyes never stopped rolling. And I was just like, what is going, like literally, like, I don't think for a good maybe like 4 or 5 months, Marley's eyes rolled constantly. Even in her sleep, she'd be sleeping and her eyes would be like cracked open, and you can see her eyes moving. And I was just like, this is not okay. She was never able to just like, I don't know how I explain it is, she was never able to be a baby.
Yeah.
And that's one thing that I always like express to her doctors, is that I just want Marley to be a baby. I just want her to rest. I just want her to learn. And I feel like that was another thing. Like, when I started noticing, like, okay, like, I know she's a preemie, I know she's gonna be delayed, but we're not getting anywhere. Like, there's no type of head control. There's no like desire to move, to roll, there was nothing. Then we got to the point where Marley was eating. She would drink her bottles. She'd love her bottles. We got to the point where a bottle would touch her lip, and then she'd start seizing. She'd start gagging. So we went from her strictly like eating on her own to not eating at all. So when that started happening, then Marley started choking over her own saliva. Like, just, I literally just watched her go downhill so quickly. And it was like, when we got the diagnosis of epilepsy, the doctor was like, okay, yep, and we have a surgery that she can do. She can have the corpus callosal. I always say this wrong. And I was just like, wait,
it's okay.
Hold up. I was just like, what do you mean? Like, because I had no clue that she was having seizures, but I knew something was wrong.
Dr. Joshi, can you kind of speak into everything that she's speaking about? Why is it so important that a baby, we need to stop a child from seizing at birth? I mean, so many people have this misunderstanding of epilepsy and why it's so devastating to the developing brain of a child.
Sure. Can
you speak into what Dami is speaking and how Marley started declining? Why does that happen?
No, that is something that we all constantly remind ourselves about, that, you may spend 30 seconds of the day having a seizure, but sometimes, as we just heard, that's just the tip of the iceberg. What's really going on underneath is a lot more frequent than that. And there's been a lot of data coming from people who do research in basic science labs, and they study brain cells, and poorly controlled seizures, they do hurt brain cells. And if brain cells are hurt, then children's brains have a hard time developing. I almost sometimes, if I have to like really simplify this and explain this to somebody, it's like if your child's brain is going to spend most of its time in a seizure, it doesn't have time to spend doing the things that it's supposed to be doing. And so there definitely is, I think, more so a sense of urgency, shall we say, to try and get children's seizures under control. It's been said that if a child is diagnosed with cancer, there is a rush to get a child to the place to treat the cancer, and you don't say, "I'll see you in 2 weeks," kind of a thing. And we like to think about seizures in children the same way. Yes. Granted, there are probably more oncologists than there are neurologists, and even few epilepsy specialists or epileptologists. But even then, you will find that almost every place, if it is a baby or a young child with seizures, everybody makes it a priority to see these children exactly for this reason. There was another thing that I was just going to say is, I've been doing this for a few years, shall we say, and one of the most humbling things that I have learned, and I remind myself over and over again, is to listen to the parent. Yes. Children's brains don't read our medical textbooks. They don't always follow the rules. And to be absolutely fair and honest, even in the children I have followed for many, many years, and I know their epilepsy story, I know what triggers their seizures, but the reality is I'm spending, a handful of hours a year with them. Even if I see them every 2 months, every month, it is 30 minutes a month. It is 30 minutes every 2 months. A family, a parent, a caregiver is with that child 24/7. So when they say something isn't right, something isn't right. And it might not be, the something isn't right might be a medication side effect. It might be an ear infection that is making a child fussy. But when they say something isn't right, that is one humbling experience I have learned over the years that I have. And there have been times when even I have said, this doesn't really sound like a seizure. Let's just be sure, because we don't want this to continue. I don't want to say, 3 weeks or 4 weeks from now saying, shoot, we should have looked at this 4 weeks ago. And I will be honest, these kids fool us, man. Sometimes what we think is not a seizure turns out to be a seizure. Sometimes what we think is a seizure turns out to not be a seizure. So I think the big thing for me, one, is to listen, and two, is to take all this very seriously when a family said, something isn't right. What do you think?
Dr. Joshi, as a follow-up,
thank you for saying that.
As a follow-up, what would you say to a parent? Like, what kind of information is helpful to you?
Sure.
Right? When a parent comes to you, what kind of information is helpful to you so that you can do what you do better,
So sometimes, there's a saying that a picture is worth 1,000 words. I don't think it's been updated for the digital age to say that a video is worth maybe like a paragraph. But one thing that I find helpful, and I use this a lot, this is even before telemedicine, is, and I think this is where particularly parents who are younger than me, I have a lot of families who are much, much younger than me now, who are way more tech savvy than I am. So I tell them to videotape what they're seeing. There are many secure platforms by which videos can be shared between a family and a physician. And I think, to me, that has been very, very, very helpful in at least starting the process, and quickly, because again, the reality is there is only so much time in a day and in a week to accommodate somebody in a clinic. But how long does it take to make a video, send it, and for me to take a look at it and say, you know what, this is a kid twitching in her sleep, I'm not worried about her. And we were pretty candid about it to say, I don't know whether this is seizures or not. Let's bring you in, do an EEG and figure it out. Or, oh yes, this looks like a new type of seizure. I know she's never done this before, but this looks different. We should be worried about it. So I think, to me, that is one thing that I tell parents a lot. If you see something, just videotape it, get in touch with us, and we'll tell you how to get it to us. I think that, to me, has been very, very helpful. I have families who present to their pediatrician's office with videos, and I don't have a relationship with the family, but if a doctor sends me a video, we can look at it. The other thing is, if you have a child with epilepsy, and you see something that is different, something that is not right, on one hand, don't feel like you're being a pain when you're alerting your doctor to something that isn't right, because things do change. A child's brain is changing, a child's brain is developing. So even if this is a child with epilepsy who follows the same pattern, things can change sometimes, and alert your doctor to them. And if it is like, oh, this was a big old nothing, everybody is happy. But if this is something that needs attention, absolutely alert your doctor to that.
Can you speak into, for somebody that is, new to epilepsy, or maybe they don't know anything about it, maybe it's a grandparent, can you explain what the diagnostic tools that you have at your disposal? You mentioned EEG. For somebody who doesn't know what that is, what is that?
Okay, that's a great question. So when we talk about seizures, epilepsy, how do we figure it out? There are many sort of pieces that make the puzzle all fit together. There is, to start with, the story and the description of what an actual episode looks like. And like I said, that's where, if you have a video, brilliant, great. But let's say you don't. Happens at school, you don't know. And then you have to do some diagnostic testing. So a very commonly used test is something called an EEG. It stands for electroencephalogram. It's a long word. Very similar to an EKG, or ECG, which is an electrical rhythm of the heart. The EEG measures electrical rhythms in the brain. Unlike an EKG, where you have just a handful of electrodes on the chest, this is a whole bunch of electrodes that cover the front and back of the head. And they, now we have very sophisticated digital displays. The nice thing is these EEGs are recorded and stored. They can be transported on disk from place to place. Maybe someday even that disk technology will go away. But that is, studying those patterns of brain waves can be very helpful to help with making a diagnosis of seizures or epilepsy. Secondly, there are situations where an EEG can be run not just for a short 30 minutes or an hour. That's often a baseline where we start. Right. But if we feel like we actually need to see the symptoms happen on EEG, many places can now do EEGs for extended periods of time. These can be EEGs where a child is admitted to the hospital and is on what I like to say candid camera, and the EEG is running the whole time. There are also technologies available where you can take EEGs home. Now that's easier said than done, because the equipment is heavy, so you can't do it for a very young baby, because the stuff on the head and all the technology that goes with it is pretty heavy. But that does exist. The other test that is done, so analyzing patterns of brainwaves gives us an idea as to what kind of seizures, what kind of epilepsy. The other test that is used a lot, which is actually pretty standard of care now, is some sort of picture of the brain. We tend to use CAT scans less and less and less. They involve radiation. The preferred test is something called an MRI, which has no radiation, and it takes really good pictures of the brain. And what we're looking for there is, things from as obvious as scarring on the brain, a bleed, a tumor, trauma, but then some of the more subtle things like developmental abnormalities. Our brains are like walnuts or pecans, where they have ridges and folds on them. And if this folding pattern does not go through the normal process during brain development, it's pretty incredible how one tiny fold that goes wrong can wreak so much havoc in the brain and cause relentless seizures. But those are some of the things that we're looking for. Now, in 2021, this answer would not be complete without talking about some of the other testing that can be done. So genetic testing has become a very large part of epilepsy also now. And this becomes really important because, 5, 6, 10 years ago, the answer would be, well, we'll know why your child has seizures. It might help next children. It might, give you an answer and provide closure. However, today, knowing a certain genetic abnormality can sometimes help guide people like me towards or away from certain treatments. So there are some genetic abnormalities where some medicines we know will make seizures worse and we can avoid them. There are some genetic abnormalities where certain medicines can make seizures better. They can actually stop seizures. So there is that as well. And particularly in a very young child where there is not a clear reason, an obvious reason for seizures, we are really advocating for early genetic testing. There are a whole bunch of other blood tests that can be done. There are some spinal fluid tests that can be done in specific situations. But really, I would say an EEG, so measuring brain waves, looking at the structure of the brain, and now looking at what your genes can tell you about epilepsy can be very important.
Dr. Joshi, I wonder, since we have Dami here and baby Marley's going to go through that procedure in a couple of weeks, I wonder, not to obviously offer advice or anything like that, but just perspective. Like, what can you say to her to give her some expectation, to set the context, to really help her understand, what to expect, really,
Sure. So this is actually great because I don't know her or her baby, but this is wonderful. So you talked about a hemispherotomy with a temporal lobectomy as the proposed surgery, and that is I could not agree with you more that is a pretty big surgery. But what this procedure does is it actually just in very simple terms sort of disconnects the left and right sides of the brain. So it prevents seizures from coming out, shall we say. I think sometimes we can see that after a hemispherotomy, there can be some weakness on the opposite side of the body, some motor weakness. Sometimes it is a new thing to have motor weakness. Sometimes it is a little worsening of a pre-existing weakness. But many young children will compensate for that to some extent. It's hard to know who will compensate how much. And I will tell you that these young kids are just incredible in how quickly they recover from a surgery as big as this. I anticipate that she will need some physical therapy and will need to continue with some of the other therapies afterwards. But this can actually be pretty game changing in terms of seizure control, in terms of now, obviously, not everybody always comes off all their medications right away, but that is something that time will tell in terms of expectations about whether you might need a little bit of medication just to keep something, just sort of keep the calm, so to speak. But if a child is on 3, 4, 5 medicines, their medication regimen is often simplified. So different places do things a little bit differently in terms of how long you'll stay in the hospital and stuff like that. But even as compared with, again, this is going to sound pretty crazy, but actually many of these kids have a pretty short hospital stay as compared with the intracranial EEGs and stuff like that. This is in some ways simpler, easier. No, maybe that's not the right word, but it's often it's often something that is not a protracted, long drawn out thing.
Thank you.
How's that sit with you? What's your response to that, Dee? How does that sit with you?
It makes me feel good. It reassures me that everything's gonna be okay. I think the only thing that really has me a little nervous is about Marley's shunt, and she has a history of infection, and that's really pretty much the only thing that really. I have strong faith that Marley is going to be fine. It's just that shunt. That shunt just...
What is a shunt, Dr. Joshi? Can you explain what
Sure.
Why is there so many infections with shunts?
Boy, the latter question I'm not going to be able to answer because I think everybody's a little bit different. But a shunt is, so the most common type of shunt that we know of is something called a VP shunt. So when there is, so again, just to take a step back, our brain normally makes brain fluid. There are little cavities inside our brain where this fluid circulates, right from the top of the brain to the bottom of the brain, and then it comes out from the bottom of the brain and circulates around our spinal cord. So when people have a spinal tap, it is this fluid that is removed, but it's removed from the lower part of the back, but it's the same fluid that circulates in the brain. Now, as you can imagine, for this brain fluid, or what we call cerebrospinal fluid, or CSF, to circulate freely, you have to have a system that, you know, is without obstruction, is without any, any kind of, the flow needs to be smooth. There are situations, some of the common situations in young children are if they've had a brain bleed, there can be, or sometimes it can be a inborn structural difference in the shape of this flow system that causes the fluid not to flow smoothly. And again, this is not, I don't like giving this example, but it works. It's almost like a little backup in a plumbing system where there's a blockage somewhere and things start backing up prior to the blockage. So in order to relieve that blockage and allow that fluid to flow freely, what the neurosurgeons do is they actually insert a tubing that goes from the ventricle, which is the fluid-filled cavity in the top of the brain, into the abdomen, which is a much larger cavity where the fluid can flow and circulate more freely. And that can actually take pressure off, that can allow fluid to circulate, because that pressure building up inside the brain with the fluid accumulating is not healthy for the brain also. Now, this is a foreign material. This is, an artificially inserted tubing. So in some more than others, they are prone to either blockages in the shunt or infections in the shunt. I don't have a good answer as to why some get infections more than others. But that is definitely that is sort of a risk and a side effect that everybody's always watching for.
Yeah.
Wow, thank you. Thank you so much for that. It amazes me how I can be in this work and, for 7 years, 8 years, and I'm still learning. And I didn't know about the stomach. So that's interesting to me. And I just know that a lot of our families come to us and they've had, it seems like when they have a shunt and there's an infection, there tends to be multiple infections. And I know I'm generalizing, but I just wondered if that was the genetic component or we just don't know.
I mean, maybe there might be a neurosurgeon who has a better answer to this than I do, but I don't know that it's clear to me why one. But yes, I absolutely agree. I have seen this where some kids get multiple shunt revisions because they run into some sort of trouble, and then there are some kids who just don't.
Yeah. So with Marley, and this is just an example, what started off like her first infection was she had an abdominal surgery. And, every time that you go into surgery, you're at risk of infection. So she ended up getting an infection in her intestines, which then caught onto the shunt. So once she got that infection, then every time you get an infection with the shunt, you have to have an ETV, which is like an external drain.
Yep.
You have to do that for 21 days. I could barely hold my baby the entire time. But once she got over that, then of course we go for surgery again. In Marley's case, 5 days later, she caught another infection. So I don't know if this is with every kid, but by my experience, I feel like once you catch one infection, you're prone to continue getting them. And that sucks. And so with Marley, her shunt used to be in her stomach, but now she has a VA shunt.
Okay.
Her goes to her atrium.
Yep.
Atrium belt. So because she's had so many infections in the belly, so now we had to move it to her, basically her heart area, right, doctor?
Yeah, it is one of the chambers of the heart. Yes, that is correct. And sometimes that works better for some, but not for others. So, so it is a little bit of an individualized kind of plan for what kind of a shunt you will get.
And Dami, right now you're sorry, Dario, you're giving us the perfect example of why Dr. Joshi trusts the parental instinct, and you become an expert at your child. And I know for me, I would show up with a binder this big. I have them over here. I have 5 of them. And these doctors are like, "Are you a physician?" I said, "No, I'm an expert in my daughter." And the respect you get, when you start sharing, no, I know my child, and I just admire and appreciate so much, Dami, how you have been on this medically complex journey from the very beginning. I mean, I told my husband the other day how blessed I am, and we are, that Michaela started out her infantile spasms at 3 months old, that at least we got to enjoy her as a healthy baby girl at birth. And for 3 months, I got to enjoy a healthy baby. Then we went on the journey to save her life, and until she had life-saving brain surgery, it was challenging. But for you from day 5 to have been on this journey, we have a Mickey's Miracles prayer warrior team that meets every week and prays for our warriors. And that Marley's always on our list, so just know that we'll have you in our prayers. And Dario, I know that you wanted to say something.
Dami, what came up for me when you were talking about the shunt infection was how incredibly brave and courageous you are, and to hear you say that you can't hold your baby for 21 days because of it, and to see your spirit and how it's always uplifted, and you're so hopeful and you're so positive, and you agree to do stuff like this and share your message and share your experience. And I just am overwhelmed by how brave you are and how you happen to be vulnerable, but incredibly powerful at the same time. And I know that, families are being served because of what you share with us. And I wanted to share my gratitude. And of course, Dr. Joshi, going back to the epilepsy conversation we had with the panelists and your insight today, it's no wonder why, you're at one of the top facilities, the top person at one of the top facilities.
Well, thank you.
Working with families to give them a quality of life that they may not otherwise experience, and helping us communicate the urgency that families need to react with when something like pediatric epilepsy is even suspected. So I, as executive director of Mickey's Miracles, one of our goals is to make sure, like you said, when parents hear epilepsy, they respond like they have heard a cancer diagnosis. Chrissy talks about that all the time. You echoed that, and I appreciate you talking about the science of it, because one thing about it from an emotional perspective, right? From a parent's perspective, from an emotional perspective, but I think the perspective that people don't get all the time is, what's happening in the brain and why it's so dangerous, right? So thank you for providing that articulate context for why it's so important.
So another thing I was going to add is, while we were talking about diagnostic testing and EEGs and MRIs and genetic testing, another thing that has really changed in the last decade or so is the idea that as a community of doctors, as a community of scientists, as a community of researchers, we need to join forces also, because I might be at one of the top medical centers in the country, but I will see even a big center like Michigan will see 20, 25, 30 kids with infantile spasms a year. For us to do any groundbreaking work in understanding what really works well for children with infantile spasms, when should we push for epilepsy surgery? It's really hard to do that with such a small number of children with a given diagnosis. And then when you think about infantile spasms, in those 20 kids, there's going to be one child who has spasms for one reason, another child has spasms for a different reason. Are they same? Are they different? So about a decade ago, a lot of people in the field of pediatric epilepsy who felt the same way actually joined forces and developed something called the Pediatric Epilepsy Research Consortium, which has now grown to more than 50 pediatric epilepsy programs across the country. And this is exactly what we want to do, which is promote collegial, collaborative research so we can answer these questions and, bring the best treatments to children with epilepsy, whether they're in Michigan, whether they're in Nevada, whether they're in Texas, whether they're in Florida, wherever they are. And it's really heartening to see some of the work that has come out of the Pediatric Epilepsy Research Consortium in looking at which are the best treatments for infantile spasms, which are what kind of epilepsy surgery questions should we be asking and answering, even looking at, other aspects of like a special group that is looking at trying to answer questions for Lennox-Gastaut syndrome. So it's really how this whole field, this community of parents, of physicians, of medical centers is moving forward to really take this on for the future.
Dr. Joshi, that answer is right there. I just want to say that answer right there is why you're going to get an invitation to be on our medical advisory board.
Oh dear. Okay.
I'm not going to put you on the spot about an answer right now, but that answer right there, and being able to provide, that kind of information and understand, what happens next, and share, findings and learnings, and really develop better treatment and care and anticipation and recovery tools. That's really what Christy really envisioned when she started Mickey's Miracles, being the advocacy and getting people to level 4. Okay, what's next?
Right.
How can we be more proactive? How can we help parents understand this better? How can we help other pediatricians and neurologists and epileptologists even understand this better, so that it's less of an issue? So we're not fighting for kids' lives, so direly all the time, and so that answer right there is why, is important, incredibly important.
Thank you so much, Dami and Dr. Joshi, for joining us on this episode of the Pediatric Epilepsy Podcast. We honor both of you and your journeys and everything you're doing to advocate for our pediatric epilepsy warriors and really taking care and helping those on the path behind us. Thank you so much.
Thank you.
Thank you, and good luck, Dami. You'll be in my thoughts for sure.
Thank you so much.
All right.
Big hug to both of you. Big hug to both of you.
All right.